Welcome to CardioCon 2023. I'm going to discuss a case of bifurcation angioplasty. In my selecting case, this is the mini crushed bifurcation coronary angioplasty. Uh, yeah. Now coming to the case scenario, a 59-year-old gentleman presented with acute coronary syndrome, history of chest pains in 5 days, and he is hypertensive, no history of diabetes, no addictions. Troponin was negative, and ECG showed STT depression in the precordial leads. Echo done that was showing RWMA in the LAD territory, with the ejection fraction was around 45. Now coming to the angio, there is very critical stenosis in the proximal LAD across the diagonal, and ostial diagonal was also very tight. So I can say there is, according to the Medina classification, it is 1-1-1 kind of bifurcation lesions. Other vessels like RC and circumflex were normal. Now coming to the strategy part, what should be done for this patient? We have in coronary angioplasty, in this patient particularly, we have two options. Either we should go for provisional, and the second option is the dedicated double vessel angioplasty, complex angioplasty. Now, before going to that, am I thinking about the simple that provisional stenting or dedicated bifurcation angioplasty? Because does this side branch really need a stent or the protection? Before going to this, we should remember that if the side branch is large enough, or if the side branch comes from the main branch with some acute angle, or if the narrowing, if the side branch is very difficult to be wired, and if the patient is very sick and the side branch appears to be relatively important, in all these categories, we have to think about the bifurcation angioplasty, because the side branch is really important. Because like in this case, in my case, coming in this category, and that shows that 50 to 20% chances of the side branch closure after PCI, maybe because of the spasm, dissection on the plaque shift, but 20% is the big number. So I have selected to do mini crest bifurcation angioplasty. These are the overview of the bifurcation angioplasty, mini crush bifurcation angioplasty, which I am going to show you in a step-by-step manner, and later on I will discuss again same slide. Now I selected a femoral root and chosen a 7 French EBU, selected filter FC wire, and patient was loaded with ticagrelor and the heparin. Both dilated with turbo balloon, LED first, and after that the diagonal. And this is the pre-dilatation view, but you can see the diagonal ostium is not open yet. So I have taken a bigger balloon, 2.75 into 15, and opened the diagonal ostia well. This is the result after the pre-dilatation of both the vessels. Now coming to the important part, chosen two stent, LED and diagonal, both the stent parked in the respective vessels. LED stent was 3.5 into 18 size, and the diagonal was 2.75 into 18 mm. Now, first I deployed the diagonal stent. I kept a 2 mm stud inside the main vessels in the LED and deployed the diagonal stent almost at 12 atmosphere. After that, I removed diagonal stent balloon and wire altogether. Now I have seen that there was no edge dissection or any perforation in the stented vessel. Now coming to the LED part, the diagonal stent was crushed with LED stent, and that was 3.5 into 18 stent, which was deployed at 12 atmosphere. So this was the result after deployment of both the stent, and you can see some residual stenosis there in the diagonal part. So it was first post-dilated with bigger balloon, even though the stent size was 2.75, but I have taken a 3 balloon and post-dilated well. And the LED also post-dilated with 3.5 into 10 balloon, and this is the after post-dilatation of both the vessels. Now coming to the final part, that is the final kissing balloon that I have done with 3.5 and 2.75 balloon, and this is the result after the kissing balloon. You can see beautifully open both these stent, and this is the stent view, stent boost images that you can see both the new carina and both the stent proposed very well. And the final, this is the final result after pot. So it was really a good result after dedicated bifurcation angioplasty. So now coming to the whatever I have done, I would like to summarize and explain to you guys so that we can recall what are the steps of the mini crush. After pre-dilatation in both the stent, both the vessels, I have parked my both the stent in the respective vessels. This is the A. After that, diagonal stent was deployed. I kept 2-3 stuck inside the main vessels and deployed the diagonal stent. In the C, diagonal wire and balloon was removed. In the D, the diagonal stent was crushed with the LED stent. And in the E, the LED was rewired. Diagonal was rewired. And in the F, diagonal was post-dilated well. In the G, the final kissing balloon. And lastly, this is the final result. So these are the steps of the mini crush, which one can easily remember. Now conclusion. The mini crush technique may be considered a very good refinement of the crush technique. And I was an OCT, I would be happy to do. I was any imaging, but unfortunately that was not there. But really it showed a good result, shown good excellent result in these studies. The application of this technique in the clinical setting of bifurcation lesions proved to be very promising. And the multiple techniques have been developed to effectively treat bifurcation lesions. And each has unique advantages and disadvantages. But I would like to say that you become a master in one technique and rest things will fall automatically. Thank you so much.